Hello, my name is James Piper. I'm a Senior Fellow and a Clinical Lecturer in the Specialty of Acute Medicine and I work for the UCL School of Medicine. This is a YouTube tutorial on the topic of shock. This talk has been updated from a previous version and is current for the 2021 academic year. So, now I'm going to talk about what shock is defined as. And it's defined as a medical emergency of profound circulatory collapse resulting in reduced organ and tissue perfusion, requiring immediate intervention to prevent end organ damage and ultimately cardiac arrest. There are multiple different types of shock, and these include anaphylactic shock, cardiogenic shock, hypovolemic or hemorrhagic shock. It's important to note that the two are not mutually exclusive, septic shock, and what's otherwise known as spinal or a neurogenic shock. Pause here and have a think about how you should assess a patient who's presenting with shock and what you should focus on in your examination. So when you're assessing a patient who presents with shock, then it's important to obviously follow your ABCDE assessment, which is covered in the talk Principles in Acute Medicine. You're going to be particularly on the lookout for signs of airway obstruction. So, for example, a patient who's becoming profoundly hypotensive is likely to lose their airway as they lose cerebral perfusion pressure. See how much oxygen the patient is on, observe their respiratory rate and respiratory mechanics. Pay attention to their SATs, respiratory rate, and obtain an arterial blood gas, especially if there's concern about their ventilatory effort. Check their heart rate and check whether it's tachycardia, or more likely if they are shocked to be tachycardic. If it's cardiogenic shock, however, such as complete heart block, then it is likely that they're going to have a complete heart block and therefore bradycardic, although this is a relatively uncommon finding compared to a tachycardia in a shocked patient. Assess a patient's perfusion, both peripherally and performing a central capillary refill time. You're going to be on the lookout for confusion, check their temperature, blood glucose, and at the end of your assessment, you're going to decide what investigations, medication, and escalation the patient needs. There are, however, some pitfalls in the assessment of shock, and it's important to appreciate the extremes of age and frailty, which give different strengths of compensatory mechanisms. For example, a younger patient is far more likely to tolerate profound periods of shock compared to a frail person who's likely to decompensate extremely quickly, and therefore the rate to mortality is higher as the patient is more frail. That said, younger patients will often hold out until they suddenly collapse and they deteriorate extremely rapidly. Remember that the measurement of lactate is a reflection of anaerobic metabolism. Septic shock, although we have got better at recognising sepsis, it still does account for about a third of ITU admissions. It's really important that you understand what patients are taking in the way of medication when assessing their circulation. Pay particular attention to antihypertensives and beta blockers. For example, even in a shocked patient, beta blockade will still be affecting their circulatory system, and therefore they'll have what appears to be a normal heart rate when actually in normal times they would be very tachycardic. Another way of assessing circulation is to measure someone's urine output. This can be via a catheter and should be a minimum of 0.5 mL per kilo per hour. A lot of you, when presenting medical student exams, often mention the word cyanosis. I think it's really important to say that cyanosis is a very late sign in acute and critical illness, and therefore if you're presenting a patient who's relatively well, don't mention cyanosis. It does make you look a little bit silly. I'd like you to pause here and think about what a fluid challenge is. This is a particular term that's bandied around quite a lot, but it is important that it is done well and properly for the reasons I'm about to show you. So the administration of a fluid challenge is 250 mL to 500 mL of crystalloid stat. And what I mean stat, I mean is as rapidly as possible, no more than 10 minutes, should be ideally squeezed in or administered via a big vein. And what you're trying to test here is Starling's law. As you can see from the diagram, if you have a fluid responsive patient who has an increase in their stroke volume, i.e. their blood pressure goes up, then they are fluid deplete, and the answer to continue fluid resuscitation. However, in poorly patients who have profound septic shock or cardiogenic shock, then actually the addition of fluid will make very little to no difference to their blood pressure. And simply what will happen is the patient will just become overloaded and develop massive pulmonary edema. It's very easy to do in the heat of the moment. When I was in FY1, I accidentally fluid overloaded a septic patient without recognising that she had tipped over Starling's curve and actually needed vasopressor therapy, not more fluid. So it's important that you're always clear when you're administering a particular fluid challenge what it is that you're actually looking for and what you're going to do if that fluid challenge doesn't work. So have a look at this diagram, and this goes between the differences between those where your stroke volume is increased with fluid, where it's decreased or no change. There are important treatment ramifications for recognising this difference. Now, when you're thinking about the differentials, it's important to think about shock in multiple different ways and also have a wider differential. So, for example, hypovolemia is not just about hemorrhage. There can, of course, be multiple different sources and means of becoming hypovolemic. So, hemorrhage is obviously the classic one. So, this can be from trauma, internal bleeding, iatrogenic, say from a perforation or a procedure. Good example being a renal biopsy. There can, of course, be hypovolemia by the urinary system, such as in diabetes insipidus and the presentations of DKA and type 1 diabetes. There can be GI fluid loss, such as through diarrhea and vomiting, and, of course, cutaneous loss, such as burns, toxic epidural necrolysis, and Stevens-Johnson syndrome. I've worked in a burns unit in my time, and obviously the amount of fluid loss can be litres and litres in patients who have advanced third-degree burns. I've seen a picture here on the left-hand side of toxic epidermal necrolysis. The other two pictures are related to the other type of differential, and that is obstructive shock. So this can be for a massive pulmonary embolism, cardiac tamponade, as seen in the middle diagram. This is a parasternal long axis view of a left ventricle, and you can see that the black fluid around the ventricle is where the tamponade is, and that's pressing on the left ventricle, causing left ventricular outflow tract obstruction. In the right hand side diagram, you can see hopefully a massive pneumothorax on the left hand side, which has caused complete collapse of the left lobes and is starting to push the trachea across. So your differential for obstructive shock is PE, cardiac tamponade, and tension pneumothorax. The next group of shock differentials is when the heart fails. This is known as cardiogenic shock. And this can be from acute myocardial infarction, which will result in pulmonary edema. It may be that the patient has had an arrhythmia such as ventricular tachycardia, and again this is likely to be seen in patients who have profound metabolic abnormalities such as hypokalemia and hypomagnesemia, or more likely after an acute myocardial infarction as sequelae. Also, secondly to a myocardial infarction, there can be acute aortic regurgitation, acute mitral regurgitation, and this can often be seen in the form of clinical endocarditis, dissection, and cord rupture. You can, of course, develop ventricular septal defects, which can again cause shunting, which then causes cardiogenic shock. In the right-hand side is a picture of the rhythm strip that you might see with a ventricular tachycardia. The final differential group is a vasodilatation, and so this is sort of fluid loss via dilated blood vessels and often therefore via the skin, or causing third space losses. And this can be caused via sepsis, drugs and toxins, anaphylaxis, and acute adrenal insufficiency. Now, when you're thinking about the presentation and management of shock, many of you will be asked to consider about organ failure, and it's important to see a shocked patient in those terms. What you want to consider is for each organ, what is it that goes in, what is it the organ does, and what is it that comes out. So for example, on the left hand side, this is a concept diagram of the heart. So obviously the heart requires blood to come in, but if for example there's reduced blood inflow due to say a stab wound, then obviously that's going to affect the input to the myocardium. Now, if we look at the structure of the myocardium itself, if let's say the patient has aortic stenosis, then obviously it's going to be considerably harder for the blood to be pumped across the aortic valve. Now, if the patient is septic, let's say, then obviously that's going to cause an output problem due to the vasodilatation and reduced systemic vascular resistance. So it's important that when you consider organ failure, as well as considering them in the round, think about what goes in, what the organ does, and what comes out. Often you'll be asked on a post-op ward round or in the acute assessment unit, how do you assess an organ, or what tests would you organise? And these are the three groups that I have suggested to you. So the first thing is obviously to think about what pathology and blood tests does this patient need. I'm a bit of a fan of the liver, so obviously I've picked liver function tests here, easily reproducible and orderable multiple times. So liver function tests are a highly useful test. The good news about most organs as well is that you can image them. So for example, I've given you a CT liver here. The other good thing as well is if you need to, you can take tissue from most organs. Even the brain can have a brain biopsy performed on it. In this case, I've obviously selected a liver biopsy. So think about pathology and tests, imaging, and histopathology if necessary. You also need to think about the range of investigations that are required and why. ECG being an obvious one, and you should write this in any patient who you clerk in who's unwell, similarly to a chest x-ray. Even if you think the patient probably doesn't need one, they probably still do. Echocardiogram is a good way, non-invasive way, assessing heart valves and also left ventricular function. ABG if you're concerned about respiratory mechanics. Basic blood tests at a minimum should include glucose, urea and electrolytes, full blood count, a lactate, liver function tests and clotting. Be aware of the difference between a group and save and or cross-match. Group and save is the blood test used to identify your major antibodies and your blood group. A cross-match, however, is the physical production of that blood type. So group and save, the lab will simply note down any significant antibodies and your blood type and put it into the computer. If you order a cross-match, you'll obviously order a number of units of blood. So for example, 2 units O-neg cross-match. Blood culture should be performed in anyone who you suspect has a sepsis of any kind, both cold or hot sepsis. Perform a urine dip, although I would urge you to try and be cautious about performing urine dips in the elderly. Due to the change in flora, they are notoriously unreliable, and so the presence of white cells in an elderly person in their urine does not equate the same as having a urinary tract infection. Microsample, so for example, if the patient has a wound, an abscess, pressure sore, for example, you should take swabs from there. And it might be that the patient needs more advanced imaging, such as a CT or MRI scan. Now, when you've performed your investigations and you're starting to construct your management plan, you need to think about these three following concepts. You need to think about your investigation and assessment and escalation. So, for example, you need to confirm how you're going to investigate this patient further. So, for example, you're going to perform an HB test every 2 hours, you're going to perform hourly blood pressures, and you're going to refer to the patient to, say, ICU or to theatres in the case of, let's say, a GI bleed. Let's say our patient's having a GI bleed, you then need to think about source control. How do I turn off the tap? So, in a case of GI bleeding, endoscopy would be the most appropriate next step. Now, in terms of resuscitation strategy, you're obviously going to think about what do I need to do to replace what's been lost. So it could be human albumin solution, blood, or IV fluids. So again, when you're thinking about managing a patient with shock, you need to be thinking about your investigation strategy, your assessment and escalation plans, your source control strategy, and your resuscitation strategy. Now I'm going to talk about some of the more specific examples of shock, and I'm going to start with anaphylaxis. Anaphylaxis is a rapid, severe systemic allergic reaction with hypotension and respiratory problems. You'll note that I've highlighted underline, and this is underlined rapid, and this is really important because anaphylaxis is not a condition that evolves over hours or days or weeks. It is very rapid in its very nature and usually presents within minutes. Presentation of anaphylaxis can vary, although typical symptoms include flushing, itch, urticaria, angioedema, nausea and vomiting, diarrhea, abdominal pain, stridor, wheeze, shortness of breath, dizziness, syncope, chest pain. Obviously, it's very frightening, but it can proceed in cardiorespiratory arrest. Anaphylaxis is usually seen in patients who are young to early adulthood. The majority of causes group into classes such as drugs, food, insect venom, exercise, latex, colloids, and seminal fluid, and idiopathic. I presume that must be why I avoid the gym, to avoid my exercise-induced anaphylaxis. Now, when we look at the age group and the different types of anaphylaxis, this is data from the Royal Australian College of GPs from 2013. You'll note that, for example, food anaphylaxis tends to predominate in the younger age group. And I think this is just a simple virtue of babies and infants being exposed to food antigens for the first time. You'll notice that there's a lull as children turn of age at the first decade, and as they become young adults, that peak rises again. And again, I think that is probably due to different exposure to different food groups as people go to university, travel, and so on. There's a steady rise in drug anaphylaxis from young age to as patients get older. I think this is just a sad fact that as patients get older, we start putting them on lots of different drugs. And so as they reach their sort of 6th and 7th decade of life, they can be on multiple different medications. Therefore, the likelihood of drug anaphylaxis by interaction becomes much higher. So when we're now going to talk about the time to death, and again, this is a crucial factor in differential diagnosis. Now, what's important to realise is that this is data from the Resus Council, and again, I suggest you have a look at their guidance as a bit of background reading. You can see that patients who have death due to anaphylaxis after an IV injection, the peak of death is between 5 and 10 minutes. So that's important to realise. So if they're concerned about drug anaphylaxis and the drug was administered within sort of 5 to 10 minutes ago, then certainly that would be the most top differential diagnosis. Now, it's not impossible to say after, say, an hour or so, although as you can see from the chart, that's much more rarer compared to death within 2 to 10 minutes. Food, on the other hand, the peak is slightly to the right, and that's probably just due to digestion time, in the same way that the spread of death time with oral drugs is quite wide. I think that probably just reflects the bioavailability and whether the drug is, how it's metabolized and whether it is enteric coated or not. So this outlines the management algorithm for anaphylaxis. So if you suspect anaphylaxis, then obviously you're going to perform your a very brief ABCDE assessment and request the anaphylaxis box. You're also going to request a senior anaesthetist, and the reason for that is in case the patient needs a tracheostomy. You need to look for the acute onset of illness. So again, the timing is important. Life-threatening airway or breathing compromise. The patient will rapidly become hypotensive. Flush, there'll often be evidence of hives, urticaria, and angioedema. If possible, lie the patient flat, raise their legs, and that is to improve the patient's blood pressure. If the patient has an EpiPen, then you should help them either inject it themselves or do it for them. The critical step in the treatment of anaphylaxis is to perform intramuscular adrenaline, and I will show the doses on the next slide. You need to order the crash team, so 2222, and then you also need to give the patient high flow oxygen. I would suggest that as soon as you have access to high flow oxygen, which for most of you on the acute wards, there'll be a high flow oxygen mask by every bed. Put this on as soon as you think a patient's having anaphylaxis. It's important they're well oxygenated in case they develop laryngeal edema, and then obviously administer the anaphylaxis as soon as it's available. Although adrenaline is the definitive treatment for anaphylaxis, it is more likely that high flow oxygen will be close to hand. Therefore, as a matter of logistics, oxygen will come on first, and then as soon as you get the anaphylaxis box, you can then administer the IM adrenaline. The IM adrenaline doses that you'll need to know for adult medicine is 500 milligrams intramuscularly or 0.5 mils. You should give intramuscular unless you're experienced with IV adrenaline, which you won't be at this stage, and therefore the only people who should be giving IV adrenaline in the case of anaphylaxis is the senior medical registrar, anaesthetist, or critical care physician. You should also give IV fluid challenge to patients likely to need litres of fluid, so probably give a litre stat for most adults. If the patient is receiving colloid, although these days that's very unlikely due to the risk of anaphylaxis, then obviously the fluid or the likely precipitant medication, if it's still running, such as an IV antibiotic drip, should be administered. You also need to give Piriton, so you can give IM or slow IV 10 milligrams as an antihistamine and 200 milligrams of IV for steroid. And again, this is the Resus Council algorithm. So other alternatives include chronic spontaneous urticaria and angioedema, but in order for that to be this diagnosis, then the patient needs to have had symptoms for at least 6 weeks, therefore making anaphylaxis very unlikely. One of the more common things you might see is ACE inhibitor-induced angioedema, although it's important to realise that there'll be no urticaria and no hypotension. Acute asthma can present clinically the same, although again there will be no itch, urticaria, angioedema, and the reduction in blood pressure due to kinking of the great vessels will be quite late. Acute heart failure is possible, even rare cases in the UK, scombrotoxin poisoning, which is bacteria from spoiled fish. Vasovagal, of course, there'll be no itch, no urticaria, no angioedema, or no respiratory distress. It is possible that the patient has acute panic or a functional stridor. And you can see that I've put urticaria on the right hand side and angioedema at the bottom picture. A different type of shock now, cardiogenic shock, results from cardiac dysfunction impairing the ability to maintain adequate tissue perfusion. Unfortunately, this has a high mortality of about 50 to 70%. It causes reduced cardiac output, so this has a domino effect on all the other organs and will have poor tissue perfusion even if the patient is adequately filled, as the patient has a primary pump problem. When thinking about the clinical presentation of cardiogenic shock, there's likely to be evidence of myocardial infarction or ACS. You may see on echo or hear acute mitral regurgitation, septal rupture. There could be myocardial suppression due to the patient being on beta blockers if they have a history of ischemic heart disease, raised jugular venous pressure, a pansystolic murmur of mitral regurgitation or ventricular septal defect, or rarely evidence of endocarditis as seen by the splinter hemorrhages here. Again, endocarditis is a relatively rare clinical presentation, so again, if your patient is very well and coming with a non-related condition, then again, I wouldn't suggest that describing to the doctor whether they have splinter hemorrhages or not. Again, it looks like your examination technique isn't particularly slick, so try and think about relevant pertinent negatives and pertinent positives. So when thinking about acute and critical illness, it's important to think about the myriad of organs that can failure and in what order. So obviously, funnily enough, you'll depend on the heart for all of the organs to function. And you'll notice from this diagram that effectively all of your major organs are linked. So obviously, if your patient has poor output, then obviously that's going to affect the kidneys and the liver, which is obviously dependent on high blood flows. So again, that can cause renal failure, that can cause liver failure. And of course, if the liver fails, then it is likely that the kidneys will then start to fail. And that's known as a hepatorenal syndrome. And obviously when the kidneys fail and can cause uremia, that obviously causes confusion, encephalopathy, and brain failure. Of course, if the blood supply from the heart to the brain is directly poor, then obviously this will cause vascular disease and therefore vascular dementia. You can also have hepatopulmonary syndromes as the circuitry of the liver and the lungs are linked, and this in turn, of course, if the patient has significant pulmonary syndromes, can of course cause hypoxic damage. So you can see by the cycle and the relationships how interconnected the organs are and how clinical syndrome in one is likely to precipitate failure and syndromes of the other organs. Management of cardiogenic shock. So your aim of treatment is to increase tissue perfusion, and the patient will probably need a little bit of fluid resuscitation, although it's very easy to tip the patient into overload, so you have to consider this very carefully. It might be that patients had an acute ischemic event in which you should consider treatment with antiplatelets, heparin, and or primary angioplasty, particularly if it's a STEMI. If the patient has an arrhythmia, then you would perform a DC cardioversion if safe. In the administration of amiodarone, which is an antiarrhythmic drug, then obviously you need a long line or a central venous catheter. You can monitor the blood pressure directly via use of an arterial line, but this can only be used in a A&E resus, HDU or critical care setting. Again, if the patient has severe cardiogenic shock, then it might be they need inotropic support such as dopamine, noradrenaline and adrenaline. In extreme cases, an intra-aortic balloon pump might be used, and even more extreme cases, or serious ones, patient may be a candidate for transplantation of the heart or left ventricular assist device. When you're thinking about hemorrhage, then obviously you're going to consider the different possibilities of where the hemorrhage might come from. So obviously think about looking at this diagram, and you can see that the patient has a pelvic binder on. So again, there's a risk of high volume loss in pelvic fractures. Patient's also got a crush injury of the left arm. So obviously this is a patient who, by the look of it, has had a traumatic injury in a war zone. You can see the soldier anaesthetist in his khakis at the top. So obviously this patient's had a major trauma and has multiple sources of bleeding, as you can see by the blood on the floor. It's important to realise that in the assessment and management of hemorrhagic shock, the symptoms often begin well before the signs. You're going to stick to your ABCD assessment and think about, again, identifying the source. What is the patient's history? So, for example, have they had evidence of melena? Is there melena on PR? And on imaging, there may be nothing. Although, if, for example, it's a retroperitoneal bleed, such as after a kidney biopsy that's had perforated the kidney, then obviously that's going to cause a retroperitoneal bleed, which will be more visible on CT. Also, abdominal aortic aneurysm can be the same. Your management strategy will, of course, include direct pressure where possible, fluid resuscitation, endoscopic measures, interventional radiology, such as if endoscopy fails in GI bleed, then you can perform a gastroduodenal artery embolization. And in the worst case, perform an emergency laparotomy and repair the bleeding directly. Fluid options include 0.9 saline, Hartmann's, colloid, blood products. Never ever use 5% dextrose in resuscitation. It is effectively giving someone IV water and has no resuscitative properties. When dealing with hypovolemic shock, then obviously you need to consider what routes of access you have to fluids. For most patients, obviously the most preferable route is, of course, to give oral fluid, followed by IV. You can, in emergencies, give intraosseous fluids via the bone marrow, via a central venous catheter, although most central venous catheters can only last in about 7 to 10 days, 14 at absolute most, and so we'll need changing, and also subcutaneously. Subcutaneous fluids tend to be in patients who are being palliated, and the family or the patient have requested that they have fluids even in their death. Obviously, it's important that you have a fluid balance chart, such as on a paper chart and also via a urinary catheter. This diagram here basically works through the different causes of hypovolemic shock, its pathogenesis, complications, and clinical findings. Obviously, hopefully, it should be fairly straightforward. Pause the video here and take some time to study this slide. Now I'm going to talk about sepsis. So septic shock is a life-threatening organ dysfunction from the body's response to infection. It is still the leading cause of death in the critically ill and has a mortality of about 50%. Obviously, as we look to the future, it's more likely that the patients will have developing problems with sepsis, and this will include the fact that our population is aging, the rise of antibiotic resistance, the fact that we are performing more invasive procedures, more immunosuppressive agents are coming onto the market all the time, and other chemotherapeutics, and this will mean that the treatment of sepsis becomes more and more complicated. Now, when sepsis was first considered as a syndrome and defined in 1991, it was first defined as a systemic inflammatory response due to a suspected or confirmed infection with 2 or more of the following criteria: temperature less than 36 or greater than 38, heart rate greater than 90, respiratory rate greater than 20, a white cell count of less than 4 or greater than 12. Severe sepsis, however, was defined as progression of sepsis to organ dysfunction, tissue hypoperfusion, or hypertension. Septic shock, however, was defined as hypotension and organ dysfunction that persisted despite volume resuscitation, necessitating vasoactive medication with 2 or more SIRS criteria. Do you think you can remember all that? It's pretty complicated and not exactly the type of definitions that you're going to be able to remember in an emergency or on a ward round. So, in 2016, the definitions were furthered simply to sepsis 3 definitions, where sepsis was defined as a life-threatening condition caused by a dysregulated host response to infection resulting in organ dysfunction. Basically, putting it another way, a patient who's sick and you're worried that they might have infection. Septic shock, however, was defined as circulatory, cellular, or metabolic abnormalities in septic patients, fluid refractory hypotension needing vasopressor therapy with tissue hypoperfusion. Basically, put simply, septic shock is where ICU is needed to give invasive vasopressor therapy. And despite everything you can do on the ward, they're not getting better. That's probably a simpler way of putting it. A scoring system, and again you can find the link to this at qsofa.org, are 3 independent predictors of organ dysfunction associated with poor outcomes in sepsis. And they include respiratory rate greater than 22, systolic blood pressure of less than 100, and an altered mental state. It is validated outside the ITU, and its main role is to identify the sicker patients. I just want to talk briefly about antimicrobial therapy. So it's important in the management of sepsis to deliver prompt, broad spectrum but appropriate antibiotics within an hour. It's important that you are mindful of MRSA history and whether there's any local patterns of resistance. As well as antibiotics, it may be that you need to administer the patient antifungals, and this is particularly important in those who have had recent antibiotics and are still poorly, perforated abdomens, immunocompromised, and those with liver failure. One of the key prescribing goals in managing sepsis is to consider your de-escalation strategy. So, for example, if you start with, say, IV piperacillin tazobactam, but you've identified the patient has a simple chest infection and is improved, you may want to de-escalate to, say, oral amoxicillin before discharge. Where possible, always try and obtain microsamples via culture, swabs, or biopsies. Now, I'm going to talk about fluid resuscitation. So obviously in sepsis in particular, you have a number of mechanisms of hypotension, which include vasodilatation, capillary leak, reduced circulating volume, and venous return. You should give a balanced crystalloid, so i.e. Hartmann solution of about 30 ml per kilo stat. Usually this involves a 1 to 2 litre bolus. Try and optimize the patient's fluid, stabilize them, and then try and de-escalate the fluids. And again, this is important to go back earlier to our Starling's curve and not fluid overloading the patient, as actually simply what happens, the patient just ends up requiring fusimide or dialysis. The lactate level is a marker of severity, and so lactate guided resuscitation effectively measures your response to treatment. So if your patient comes in with a lactate of 6 and this starts to improve down to, say, 2, then you have had a successful lactate guided resuscitation. Think about how you're going to identify and manage a source control. Antibiotics may be fine, but if the patient has an abscess, it is highly unlikely the antibiotics will penetrate the abscess if it's big enough, well enough, without surgical intervention. As you can see, the surgeons are about to operate on someone. So do consider involving the surgeons or interventional radiology if the patient needs a drain and a washout or a drain putting in. To restore the blood pressure, then this is due to the loss of a sympathetic tone, and so vasopressors and inotropes can restore the blood pressure. So vasopressors are medications which squeeze the blood vessels, increasing your systemic vascular resistance, and inotropes are more cardio-specific and work on increasing the cardiac output. Your mean arterial pressure goal is 65 millimeters of mercury, and noradrenaline is the first-line agent across the UK and the world. Neutropenic sepsis has a relatively common presentation to the emergency department. It still has a mortality of 2 to 21%, although ICU management is needed in less than 5%, and that simply reflects that we are getting better at recognising neutropenic sepsis early on and treating it accordingly. Patients at high risk of neutropenic sepsis, such as those who have haematological malignancies, will often get ciprofloxacin prophylaxis. Neutropenic sepsis is defined as those on anti-cancer treatment with a neutrophil count of less than 0.5 and a temperature higher than 38 degrees or other symptoms consistent with clinically significant sepsis, and that definition is from NICE. There is a NICE guidance on neutropenic sepsis. Usually the patient will require immediate empiric therapy such as tazocin or piperacillin tazobactam, performing blood cultures and also line cultures if they have a chemotherapy line in situ. And finally, neurogenic or spinal shock occurs after spinal injury, therefore is not dealt with the acute medical service. But as it's mentioned as a type of shock, I just want to spend a couple of minutes talking about it. So neurogenic shock will usually occur after spinal injury, such as a road traffic accident, and is a physiological loss of all spinal cord function caudal or posterior to the level of the injury. Clinically, this causes flaccid paralysis, numbness, and absent bowel and bladder control, and a loss of reflex activity. Unfortunately, neurogenic spinal shock may last several hours to weeks and is usually managed by a spinal team and the neurosurgeons, therefore not acute medicine. So that concludes this tutorial on shock. If you have any questions or comments or feedback, obviously please feel to like, subscribe and comment on the YouTube video, and of course you can contact me via my UCL email address. Thank you very much for listening.